So it is a very exciting time in the field of hematological malignancies, but particularly in mantle cell lymphoma, where we have, again, more and more options. So we had a new BTK inhibitor, second generation, acalabrutinib, that was just approved. While we already had ibrutinib that had been approved previously. So ibrutinib is usually associated in a phase 2 study in a response rate of 67%, and then with a CR rate about 20% that goes up to 40% after 1 year of treatment. Median duration of response around 17 months, and there was an interesting follow-up at ASH, sort of a grouping trials with long-term follow-up over 3 years. There's still 1/4 of the patients that are doing well and progression-free with ibrutinib as a single agent. So it is really interesting. However, there are some side effects with ibrutinib, although this is a well-tolerated drug. Overall, there's issues with AFib, about 5, 6, 7% depending on the studies, and then particularly in patients with cardiac history, and it has to do with an off-target effect or a rash and GI symptoms, fatigue, and some bleeding. Overall, the toxicity profile gets better over time. Acalabrutinib has a response rate that is 80%, half of them being CRs, and the median duration of response we don't have, it's too early, but the toxicity profile was very impressive. We had no cardiac toxicity at all, and it has to do with the fact that this is a quote-unquote cleaner kinase with much less off-target effect, particularly no elimination of TEC that was responsible of the cardiac toxicity and AFib, or EGFR that would be responsible of the rash or GI toxicity. So this is something that is really important, and depending on the context, I might offer an alternative option.